So, welcome everybody. Bienvenue à tous et toutes. We do have simultaneous translation here, so for my colleagues, Franco-Ontarians, and les Québécois, les Québécoises, you'll be able to hear in your own language with your headsets, so that's good. This session is about integrated, I think I wore my voice out this morning. There we go. Integrated healthcare partnerships, and your program may indicate that there are 3 presentations. We're only going to be enjoying 2 presentations today, but they're both fabulous presentations, so never fear. We've got some great presenters for you. I want to start off by doing what I did this morning, which is to acknowledge that we are on the unceded territory of the Mi'kmaq, and we all need to recognize and appreciate the stewardship of the lands and the waters and the air that they have provided to us that gives us the privilege to be able to meet on these lands. And what I often do is ask people to take a moment and reflect on the land that you normally work on, live on, play on, and recognize the need that we all have to work towards a better way of working together. Reconciliation is a big word, it's an R word, but we all need to work towards it, don't we? So, pause for a moment. So we're going to have a little presentation, just a couple of housekeeping things. Kathleen is our fabulous volunteer over there. And so we want to acknowledge all of the volunteers and appreciate the spirit that Halifax has shown to us at this conference. I've just been so impressed. It's so much fun to walk in the door and have somebody greet you and say, hey, isn't it a fabulous morning? And I was here pretty early this morning because I had to prep for my little thing on the stage, but it's fun to have that spirit of Halifax. So thank you for being here, Kathleen. We appreciate it. And just for us, we're going to hear 2 presentations. They're about 20 minutes each. And then you're going to have an opportunity to ask questions. Now, all of these sessions are being recorded, and there's a camera over there. So we ask you, please, if you stand up to ask a question, please make sure you don't block the camera, because otherwise we're going to have a fabulous shot of the back of your head, which may be good or not good, but it just isn't what we want. So there is a handheld microphone. So when I call on you to ask a question, Kathleen's going to run over and bring you the microphone. Please don't start asking your question until you have the mic. That's your talking stick, okay? Because again, we need to hear your great questions, and we also need to hear the answers that the panel is going to give to us. So with all of that said, I think I introduced myself this morning. I'm Sam. I'm one of the board members of the Canadian Alliance, and I am very pleased and honored to serve you today as your moderator. And I'll do my best to make sure that you get all the questions asked and answered, and if not, you can come and talk to the panel afterwards. I'm sure they'd love to speak with you. And this is the kind of session where I think all of us will learn something. So if you can go away with just one good idea, then I think it will have been worth your time here for the hour and a half that we're going to spend together. So without anything further, let's have our first presenters, Jose and Ines.
We'll test that. Okay. Good morning, everyone. It's a pleasure to be here. I'm Ines Broadhagen. I'm the Manager of Contracts and Analytics for the Kenora District Services Board. I'm also the Coordinated Access Data Lead for our district.
Bonjour. Welcome, everyone, and thank you for spending time with us this morning. My name is Jose Mantle. I am the Housing Solutions Manager for the Kenora District Services Board, and I am the Coordinated Access Lead for the Kenora District as well. So we do want to start with a short land acknowledgement. We are grateful to be here on Mi'kmaq territory. Ines and I both live and work in Territory 3 in the Kenora District, so northwestern Ontario, and we also encompass Treaty 5 and Treaty 9, working closely with our Indigenous, Métis, Anishinaabe and Inuit partners in a close, very committed manner to reconciling and better outcomes for all of our residents across our district. Thank you. So this morning we're going to start with a short picture of homelessness in our region, and then we will talk to you about specific homelessness support services, really focusing in on health, which is a real focus for us, and improved outcomes across our district. The next steps, and then we'll happily answer any of your questions. So the Kenora District, yesterday Ines and I heard a lot about the fastest growing cities. I can tell you that the Kenora District is not the fastest growing district in Ontario. However, I want to add that it is the most beautiful corner of our province. Ines, I think Ines agrees with us. We're both very born and raised in the area, so we are very proud to be from the Kenora District. So the Kenora District is a catchment of 407,000 square kilometers, or about 38% of the land mass in Ontario, ranging from the Manitoba border east past Ignace to the Rainy River District and then to the 14th baseline. The vast geography includes 9 municipalities and 4 unincorporated areas, with small villages and vast remote areas. In addition to approximately 7,000 people living in this area, the Kenora District also encompasses 43 First Nations. Sioux Lookout, which is the community that will specifically speak to ending homelessness, or our journey towards that today, has a population of 5,600 people and is a hub community for about 30,000 people from 33 remote First Nation communities, many of which are only accessible by air, so have no road access. Some have winter road access, but many are fly-in only. So Sioux Lookout is a very important hub community for health services, general supply runs, justice services, and many, many other services. So it's a busy little community.
The 2021 point-in-time count for the Kenora District recorded a total of 221 total homeless individuals. Sioux Lookout has the second highest rate of homelessness in the Kenora District. Of those who completed the point-in-time count survey, the majority of individuals stayed in either a homeless shelter, unsheltered in a public space, or at someone else's place the night prior to the study. There are a total of 88 emergency shelter beds in the district, located in Sioux Lookout, Red Lake, and Kenora. For the year of 2021, the Sioux Lookout Emergency Shelter reported a total of 8,892 bed nights. Point-in-time count survey respondents reported spending an average of 108 days homeless in the prior year. The pandemic, poverty, and housing crises in the communities continue to have a direct and significant impact. Between 2011 and 2022, the KDSB saw a 320% increase in housing applications on the wait list, totaling 1,332 approved applications in July of 2022. Studies have found that existing community housing in Sioux Lookout is not meeting current demand, and housing in recent years has become increasingly unaffordable and unattainable. Poverty levels, unemployment, and core housing need are amongst the highest in Ontario and Canada and are increasing.
For a number of years, the Sioux Lookout Emergency Shelter has provided essential services for unhoused or houseless individuals. New to the community is the establishment of a safe sobering facility. Currently, the facility has opened 16 safe sobering beds, and as of next week, we'll be opening 8 non-medical withdrawal detox beds. Prior to this new development, individuals requiring detox services or the start to their treatment journey had to travel to Kenora, outside of the district, so either Rainy River District, Thunder Bay District, out of the province, or Southern Ontario. which you can imagine for many, especially from a remote community, not only do you have to leave your home for healthcare, but you also have to leave your home for a very difficult journey. So with the opening of these, and this vision, which we'll get into as we continue, it will provide some opportunities for people to stay closer to home or closer to their friends, their family, and their communities. An assessment done in 2020 on housing addictions, treatment needs, and demand highlighted an urgent need for additional mental health and addiction services and supportive housing for individuals with substance use issues in Sioux Lookout. Sioux Lookout has some of the highest rates of harm due to alcohol or substance use in the province. 2/3 of homeless individuals cite substance use as being a reason that is accountable for some of their homelessness. The 2020 assessment determined that in order to serve the individuals requiring addiction treatment in the Sioux Lookout catchment area, the municipality would need to open 15 withdrawal beds, 184 treatment beds, and 2,190 supportive housing units by 2035. Since August of 2018, Sioux Lookout has also benefited from a 20-unit supportive housing program. So we'll view a short video on our supportive housing unit that opened in 2018. Yep. Should click right on the photo. Is our video not working? It's embedded. So I'll talk to you about a little bit about supportive housing while we're waiting for our video. It is embedded in the presentation, so I'm not sure why it's not coming up. But Sioux Lookout supportive housing was something that we started talking about in 2015. We did a gap analysis on what we need in the district around housing, health, social. And we had assessed that, hey, you know what, supportive housing is something we really don't have. Let's do an 8-unit build. And then our partners at Ontario Aboriginal Housing came along and said, hey, we have some funds, why don't we partner? And we opened a 20-unit program, which provides supportive housing for 10 women and 10 men under one beautiful building. And our partners in this program are Ontario Aboriginal Housing, Kenora District Services Board, Meniawan Health Center, which is located in Sioux Lookout, the Nanadawi Waywin, and First Step Women's Shelter, along with the Anishinaabe Friendship Center. So all of us work very hard on this housing program. Yeah.
I think it needs Wi-Fi, I think.
So we'll get the video loaded up. Anyway, so we opened in 2018, and since then we have been, learning as we go, because we certainly found out quickly that one of the things that did happen is we opened, but we were lacking those health partnerships. So now we have an application in for PSW supports for our individuals. Many of our individuals came to us already with, advanced stages of addiction. Health problems. Many had other existing health problems that they came to us with. So we realized that health component really needed to be solidified. So we continue working on that. And then the other health partnership component that we'll talk to you about is our addiction services that came together through an alliance and a partnership of First Nation communities along with the Sioux Lookout municipality, basically coming together and saying we need to have services that are regional. We can't keep sending people away. People can't do well when they're far away from not only their home, their friends, but their culture.
I'm not seeing
So,
the play button.
one of the things that came about is that they did a proposal. So as we continue, I will talk to you. I do have it on a USB
I could look it up on
stick.
YouTube too.
USB would be better, yeah.
Do you want my
Yes.
USB stick? We had embedded it, so I apologize for the little. When in doubt, bring your USB stick, right? Always, always. They keep telling me, you shouldn't use those anymore, but I am old-fashioned. So, there you go. you got it.
Well, here-
So as you'll see, one of the things that we do, we are a district social services administration board. We closely work with our Indigenous partners. So we have several memorandums of understanding. So
That
with
might need Wi-Fi,
Anishinaabe
though.
Nation, we have MOUs
Wi-Fi
with
sketchy.
Grand Council Treaty 3. We also work very closely with some smaller tribal councils on various things from, improved housing
there's no play
to
button
student
showing up.
housing. So many of you are maybe familiar with the difficulties around our Indigenous students coming from the north to some of our larger communities. So one of the partnerships that we've done, so I'm gonna keep babbling on about the wonderful things we do that are not really health related, but kind of are. So what we did with Wendigo Tribal Council out of Sioux Lookout is we looked at student housing because we want these students to come to school in our district and not send them even further from home, because it's just one flight to get to Sioux Lookout, right? So you go from Kitchener-Coos, Inawug, right into Sioux Lookout, and then you go to school. So we did family homes. So we basically have large homes with 6 bedrooms where 6 students live, but they don't have a staff person staffing the house. It's a family from their community that comes with them for the school year. So they're at home with home. So we really worked with a lot of elders on making sure that we are not only looking at the way we do health services and the way we do housing services, but really looking at what is the best for these individuals and these young people to have really good outcomes, to be able to pursue their goals, whatever they may be. So whether they're going to be working back in their home communities or working in our district. We're really committed to making sure that many of you know that some of our students from the north have had some really traumatic outcomes with education. So we really wanted to be part of stopping that. So that is something else that we have worked closely with our partners on. So,
I'll play from the slide, I guess.
there we go. There it is. Is it working? It's a really good video. So I really want you to see it. So the video not only really highlights our supportive housing unit, which I can tell you it is my baby, because I was very, very involved in not only identifying the need, but really we were there. We opened the doors, we were building beds as people were moving in because everything was last minute, you know how it goes. And I had the great honor working with our elder that supports us in this program. We just finished our naming ceremony, and when we went to the naming ceremony, he pulled me aside and I thought, oh, what did I do wrong? Because we are on a very crucial learning. I am not of the Indigenous culture, but I am a learner, and my learning journey continues. So he pulled me aside and handed me a smudging bowl, and I started to smudge. And he said, no, you need to smudge the building. And I was so honored. I'm going to cry. Very honored to walk the perimeter of that
Ask you to
building.
Please speak in the microphone.
Oh, sure.
You're not doing that.
Very,
They
I'm
can't
just trying.
translate.
Oh, ben je pourrais le faire en français aussi, mais. As I walked the perimeter of that building, I think the creator was telling me to keep doing the work that we're doing across our district to ensure that we have better and improved outcomes for all in our district, not only us, but our northern First Nation communities that are our neighbors. So,
1 second here.
oh, okay. Oh, we're not connected to the internet? Oh.
Wi-Fi dropped out yesterday at some point.
Okay. Do you want me to answer some questions while we're waiting? Okay.
Just wait. No questions. and then
No?
bring you a microphone.
Okay.
Bring you a microphone first. It's really critical because we've got translation
Ah.
happening and we've got recording going on, so
Yeah, it's
we
not
need to be
playing.
able to hear you.
Test.
Yeah, like it's not.
You put a microphone in my hand and you might have some problems, though, that's the
You
issue.
won't connect to the internet?
I'm on, but it's not playing.
Can we go YouTube?
Yeah, we try YouTube.
So just a curiosity, I'm from BC, and a lot of our programs work closely with the Division of Family Practice, and I was just wondering how connected you are in this work regarding working with DOFP.
So we do not have any, so this is specific to like health partnerships in our homelessness sector. In our district, we do not have a youth shelter. We have a shelter, we have 3 shelters, one in Red Lake, one in Sioux Lookout, one in Kenora. We do not accept youth under 18, what happens is
Diverse
we
hires
keep
add
them
value through
safely, and
education,
then they go on to
experience,
their
and expertise.
other,
That's the edge that
their
grads-
child welfare provider. Now, is that a need? Maybe it is. So here's our short video. So.
What is home?
What is home? I think home is where you choose it to be. Home is where you're safe. Home is where you have support.
Home, where you're safe, you feel loved, you're appreciated.
You can just relax and breathe and just have your own time, your own space.
Knowing that you're going to be okay, being able to reach out to other people.
Home is where you choose that to be, and they've never had that option to call a place a home. Our tenants have never had that opportunity, a lot of them.
What is home to you?
Stability.
Having a home is probably one of the most important things in a person's life.
It's necessities, but some people just think, take it for granted, because it's always been there.
It's something that everybody deserves and not everybody has.
Sioux Lookout's had a negative housing situation since I came to Sioux Lookout in 1975 or 76.
The issue of homelessness, the issues of addictions, and the issues of mental health, that is the largest percentage that we deal with on a daily basis.
All communities have these issues. We continue doing the same thing over and over.
People may not understand, we didn't choose to be homeless.
It's very difficult to get a job when you sleep in a derelict car at night. It's very difficult to get a job when you don't have a watch.
You can't work on anything. The trauma, the addictions.
The housing first model, that's really what needs to be in place first and foremost before we can address any further concerns.
The supportive housing unit here in Sioux Lookout opened on the 15th of August, 2018.
There are 20 units, a wing on each side with the kind of hub and the kitchen in the middle. Supportive housing gives that basic need to every individual, any individual that needs that roof over their head.
Safe and affordable housing with supports. Bringing in the supports on site to ensure that people can move forward in whatever that means for them.
At the end of the day, this money is taxpayers' money, and it's much more efficient to provide someone with housing than to leave them on the street and having them dealt with in a reactive manner.
There's safety, there's companionship, there's friendships. It feels like a big family.
It's a relief to have. It's a blessing.
We're providing people with a new start.
Giving them a chance to have a better life is really what it's about.
You're only as strong as you're most vulnerable in your community.
I don't think I've ever seen the agencies in Sioux Lookout work together as much as they have.
Basically, anything specific to a tenant's need, supports will come in.
We have already seen great successes with people, getting away from addictions and becoming functioning members of society.
Just having the security of knowing I can come to my home.
To see the smiles and the pride, it's an absolute pleasure and an honor to be a part of a project. Sorry, such as this.
So since then, we've opened an 8-unit build in Red Lake, and we're in partnership with Ontario Aboriginal Housing again, about to open a 30-unit build in Kenora. I am terrible with mics. I should have one attached to myself. I usually speak very loudly. So one of the things that was obviously a very, very great need in our community was the need for addiction. And I don't need to say too much about this slide. The rates of ED visits are 8 times the provincial average. That's all we need to say about this slide. And from 2013 to 2018, emergency department visits went from 12 to 62 due to opioid use, which is a 417% increase. We can go to the next slide. And how could this came to be? Again, I talked about the Friendship Accord, which is the municipality of Sioux Lookout working with Cat Lake First Nation, Slave Falls First Nation, Lac Seul First Nation, and Kitchener-Inawug, which is Big Trout Lake First Nations. They basically formed a partnership working on several things for improved outcomes, one of them being regional addiction services. Put a proposal into the Ontario Ministry of Health and Long-Term Care. It was approved. November 2022, we started to meet. A site was selected. In the meantime, the DSAB, so the Kenora District Services Board, had purchased a surplus school, the Queen Elizabeth High School, built in 1953, and that became ours. We divided the campus in two. The Seven Generations Education Institute is our neighbor, so they have half the high school. They are a post-secondary First Nations, Indigenous-based cultural education institute. And the other half is the Sioux Lookout Emergency Shelter and Safe Sobering Program. So partners are the Nanati-Wee-Wee-Win, First Step Women's Shelter, Sioux Lookout Emergency Shelter, Sioux Lookout Friendship Alliance, Ontario Ministry of Health and Long-Term Care, Menayawan Health Centre, and the Kenora District Services Board. So current on-site health partnerships we are lucky to have Menayawan Health Centre closely working with us. We have a rapid access to addiction medication and primary care clinic. We have one physician, Dr. Bell, who we would have loved to have with us, although if Dr. Bell isn't providing service to Slate Falls First Nations, he's working on making sure we can make our RAM clinic 24/7 to support our addiction program. And if he's not doing that, he's delivering babies in Sioux Lookout. So he's a busy guy. We also have the Northwest Health Unit Public Health Clinic. We have a dedicated public health nurse that is on site at the shelter and safe sobering site every week doing a suite of services. And we also have the Sioux Lookout First Nation Health Authority, NODN, Outreach, Mental Health and Addiction Crisis Intervention Team that provide outreach services. They also have an on-site office where they can meet with co-clients of the shelter, safe sobering, all of that. Safe sobering is also not only for homeless or unhoused individuals. It is available to anybody. It's a diversion from cells. And it is a really good way of supporting individuals in those situations. And we have the First Step Women's Shelter who offers a housing worker. So we're located in an old high school built in 1953. Here's a quick view of what the high school looks like. So it is an old brick and mortar high school, and we are in full-blown renovations currently. So we have 16 safe sober beds open. We have 8 withdrawal non-medical detox beds next week that will open. Our phase 2 would be a 24/7 RAM clinic. They're with us 2 days a week. We're going to 24/7. We have service provider space, and our third services are 30-day stay sober living while you're waiting for addiction treatment, because currently that is not available. People go back to home or wherever, and it's very difficult for them. And then our phase 4 is a 1-year sober living site. So this gives you an idea of our renovations. The center area is very important because that will be our cultural teaching and gathering space for individuals as they go through their journey. And we'll just give you some quick stats, and then we're going to be done.
As I walk towards you.
Quick walk through the stats. In the first quarter, the treatment center had a total of 177 admissions. Of those, 163 clients were unique. The average length of stay was 1.3 days. The second quarter, we saw 293 admissions with 171 unique clients, the average length of stay being 1.8 days. A total of 19 staff have been hired for the program to date. Clients are mainly in the age range of 25 to 39, and the gender distribution between male and female is approximately equal.
This is the team that makes it happen. So without them on the ground, we would not be talking to you today. So we have a really dedicated group of individuals with a lot of really good lived experience, very skilled, And I'll tell you, it is a great pleasure to spend time with these individuals, because if anybody makes it go, it is them. So we are very grateful to this team. So thank you very much. We apologize for the little glitch in the middle of our presentation, but it was an honor to share this program with you. And we will pass it on to Erin Mifflin from Peel Region. Thank you very much, everyone.
Okay, good morning, bonjour. Can everybody hear me okay? Yeah. Wonderful, thank you. As Jose said, my name is Erin Mifflin. I'm coming to you today from the region of Peel. I'm an advisor in housing innovation and program design. Sorry, I just feel like I need to get this off my chest. This is one of the first times I've presented to a live audience rather than my laptop in a really long time. So the 3D thing always blows my mind a little bit. I want to talk to you a little bit about Peel to give you the context of where I'm coming from. But my role as an advisor is I'm focused on addressing challenges and opportunities in our housing system. And my team and I act as the strategic planning arm that supports our frontline operations staff. And I just want to point out that they, even though I'm speaking today, our frontline staff have a critical role to play in this design as well. I also wanted to point out that I'm coming at this work from a housing perspective. I'm not a healthcare professional, nor do I claim to be an expert in health, but I have learned a lot and I'm continuing to do so. So I am going to tell you a little bit about Peel, talk about the context of housing and homelessness in Peel, our journey in developing a community model of care, key elements from our co-design, how it all came together from a housing perspective, and my final thoughts to leave with you. So the region of Peel is just west of Toronto, for those who might not know. We have about 1.5 million people who live there. In the last census, about 95% of our population live in the cities of Brampton and Mississauga, so we are predominantly rural. The town of Caledon is just 5%, but it will be growing. There's a lot going on here, I guess is what I want to say. Again, just to set a bit of context about what a regional government is, in case you might not know. So there's 2 levels in our region. Many of our services that the region provides through my Department of Human Services focuses on providing services to vulnerable residents. And these services that are in black are the services that are provided by the region, and the ones in gray are the services provided by our locals. Within our services, we partner with community agencies, we deliver programs, and we provide backbone infrastructure support to a multitude of initiatives. For example, we fund community housing providers, also known as social housing providers. We build new affordable supply and fund agencies that support people experiencing homelessness, and we also support people who are in precarious housing. Another example would be community safety and well-being, which is administered through our public health staff. So I won't go into too much detail about our slide here about our affordable housing system, but our role as the service manager for housing and our relationship with stakeholder and clients is very complex. I just want to remind the audience who might not be from Ontario that we're a bit different from other provinces because much of the responsibility for housing was transferred to cities 20 years ago or so. But we provide system oversight, strategic planning and advocacy, funding, we build new supply, we support clients, we're in direct delivery as well. It's complex and it has evolved significantly. So how do we manage our responsibilities? Well, we have a blueprint that we call the Peel Housing and Homelessness Plan. This was approved in 2018. However, since it's been approved, more residents of Peel are living more affordably, but we're still falling behind. We need a fully funded investment strategy. So we have to pick and choose where we put our resources. And the reason why I'm showing you this is to really focus on number 1, which is one of the pillars of our plan, which is transform service. And that's how we got into the homeless healthcare space in the first place, because we're looking at really changing how we deliver services to our clients to help continue progress towards ending chronic homelessness and help preventing more people and families from becoming homeless in the first place. Homelessness programs in Peel. So we have a street homelessness program. We contract with Canadian Mental Health Association of Peel Dufferin to provide outreach services on our behalf. They operate a street helpline, which is available any day of the week, 24/7, as well as mobile outreach vans that provide 12 hours of service. And we're getting more into place-based supports too in areas that require more support. We also run a regional shelter program of 7 shelters. We have approximately 500 beds, plus we have lots more in our overflow that are all full right now. We have our shelters this week are about 300% over capacity. This is just a snapshot of what homelessness looks like in the region of Peel from last year. I will just say that we've seen an explosion in this population this year. There's a significant increase, particularly a significant portion are asylum seekers. For example, 67% of our shelter beds right now are taken by asylum seekers. But you can see that's just some key demographics of our homeless population, just to give you a sense. So, I didn't make this slide, this is from Healthcare Excellence Canada, but it really says it all in terms of the impact of homelessness on health. The average lifespan of someone experiencing homelessness is much lower. They can be 4 times more likely to have cancer, 28 more times more likely to have hepatitis C, 5 times more likely to have heart disease. Because of the impacts like these and others, we felt compelled to respond to homeless health care, although we are a housing department. So, despite having 1.5 million people and having 2 very large cities, we do not have any dedicated sustainable funding for integrated healthcare services for people experiencing homelessness in Peel. So how do we develop one and how do we get one? We put together a co-design table of 25 organizations and people with living experience. It's grounded by them, and we're hoping to have this program done by the end of the year. So I wanted to share this in case there's other municipalities or other organizations who don't have the benefit of having a robust healthcare system in their local area, but they still want to do something in this space, because you can realize some really transformational things. So as part of our, as part of our journey with getting into the health system, we realized that through our, I'm missing a slide. Okay, never mind. Okay, well, I wanted to talk a bit about our COVID isolation and recovery sites. So the first bullet point talks about that here. Over a couple of years, you can see that we had 4 dedicated sites. One was specifically for people experiencing homelessness, and at that site, we believe we prevented an estimated 272 COVID cases, 177 hospitalizations, 70 ICU visits, and 48 deaths. People who were unsheltered on intake were 80% more likely to improve their housing status. Over about a year and a half, we had just under 3,000 individuals participating in this program. And that really helped us get to where we are today. It was the genesis of our existing interim model of care. We were able to provide a lot more funding to community partners through COVID funding streams, and it helped us build capacity and strengthen existing partnerships. It also allowed us to form new ones. We would not be where we are today without the COVID response. And all of our partners and care providers added a new dimension in our community, a new opportunity, and allowed us to expand the potential and vision of what was possible. So we needed to secure funding from our regional council. It was critical to have this in order to maintain services. Remember, we were losing our COVID funding from senior levels of government, but we were realizing some very positive impacts from providing regular access to primary care services to our clients. So we were very thankful to our council for their support. Last March, they approved funding for up to 19 months of health care for people with complex care needs. It opened in June, and we're also funding a mobile community nursing program that goes to our shelter sites as well as drop-in areas. Our Dundas Street shelter, with 25 beds for complex care, 15 for COVID. That was for most of this time period, although now we have 45 beds for complex care. I won't go through all the stats, but you can see the impact is pretty significant for a very small shelter. We saw 243 patients, and 215 were discharged with stable health. Medical services are provided here by Homeless Health Peel, and Salvation Army provides other shelter services. In terms of hospital diversion, so our Dundas Street shelter has resulted in significant savings to our healthcare system. An average hospital stay is over $900 a day. A hospital stay at Dundas is less than $250 a day. So we've saved our Peel hospitals significant savings. And I can tell you that our hospitals represent about 1/3 of all our referrals to the site, so they're well aware of the role that the shelter can play. For the government folks in the room, here's a governance structure that might tickle your fancy, how we actually get things done and get the support to make decisions and get funding. So I just want to draw your attention particularly to the Leading Practice Advisory Committee. Because we're not in health, but we wanted to make sure that we were doing the right thing, we reached out to a number of leaders in the homeless healthcare field in Ontario outside of Peel, and they have amazingly come together to support us and provide us with advice and guidance as needed. They come to us from Inner City Health Associates in Toronto, the Hamilton Shelter Network, Ottawa Inner City Health, and someone who is retired from the Toronto-based Street Health Community Nursing Foundation. They have provided us with some great advice, and they will give us feedback on things like human health resources, inclusive low-barrier healthcare delivery, how to prioritize services, referral pathways, etc. Our steering committee is made up of senior leaders from housing and health services at the region, our 2 hospitals, our 2 community health centers, one of our Ontario health teams, a representative from a family health team, and 2 key community agencies. And the steering committee provides us with advice and direction to our co-design table. So our co-design table are people who have expressed interest through a formal request for expression of interest from the health and housing homelessness sectors, and it also includes people with living experience of homelessness. And this is just a shout out to the organizations who are participating at our co-design table. We're very thankful for their support, and keep in mind also that because Peel hasn't had any sustained dedicated funding, this area was quite fragmented. So it's fantastic that we've been able to pull together. So as I mentioned, we issued a request for expression of interest so people and organizations could apply. And through this EOI, we offered up options as to the level of engagement that people might want. This really resonated with our community, and we got a wide variety of folks that wanted to be informed, consulted, or involved. And the stakeholders are people with living experience of homelessness, healthcare service providers, supportive housing providers, advocates, housing and homelessness agencies, and engaged citizens. It's a really diverse group. It's fantastic. This is our timeline. So it takes time to do things right, as we all know, especially when you're trying to be collaborative and you're co-designing with a bunch of different people who all have great ideas, but you're trying to coalesce it into something you can move forward on. So we're getting deeper into the health system space, which is great, but it's outside of our comfort zone because we're coming at this from a municipal housing lens. So before the end of the year, we're finalizing what our sustainable model will look like, and we'll be seeking validation and seeking funding. So as part of the validation piece, we have been regularly committed to engaging with our clients and with other people about living experience of homelessness. So this is an empathy map. An empathy map is a collaborative tool to gain deeper insights with your customers, or in our case, with our clients. We were seeking a better understanding of our clients' thoughts about their experiences with their health and our healthcare system. So it's divvied up into quadrants here. We were interested in hearing about how they think and feel, what they see, what they say and do, and what they hear about their health and their experiences with our healthcare system. We also were interested in storytelling and narrative. So facilitated through some of our co-design table members who have already built up close and trusted relationships with some clients, 16 clients completed a booklet that tells their story about themselves, their health, and the health system. Some clients chose to express their thoughts through art, which we were tickled pink to get some of this feedback, and this one is amazing. This one is a youth who drew out their experience of how they became homeless, and then how they eventually got to our transitional housing site for youth, Peel Youth Village. So started living with his grandma, moved out, went to school, got schizophrenia, traveled to Jamaica, back to Canada, got worse, worked for a few months, lost his job, became homeless, was needing some help, got moved around a bit, and now he's at Peel Youth Village and feeling better. So it was a really powerful way to get at feedback from a different way. This is our overarching goal that was come together collaboratively by our group. We want our integrated, sustainable model of care to help improve the quality of life of our residents. So we want an easily accessible and responsive healthcare service that is high quality, integrated, and sustainable for people experiencing homelessness or transitioning out of homelessness in Peel Region. And this exercise has already yielded numerous benefits. And here's an example of a client who also filled out our booklet and expressed their positive feelings after having been asked to tell their story. We know sometimes it can be triggering in a negative way, but it was really nice to see this, that they felt good after doing it. So as part of our work, we needed to understand the current state in Peel. As you can see, I'm not trying to toot our own horn, but it is what it is. Without the region, most of our healthcare services for people experiencing homelessness would be in jeopardy. And the amount of resources and staff do not currently meet the need that we experience. It's important to really understand your starting point before you talk about making enhancements or changes to your system. So, current state. I can't share the final model at this time, but as I said, it would be completed by near year end. I'm happy to keep in touch with those that might be interested in the final product, but we are continuing to work away in the background on the various elements that will help make our model a success. So key elements from our co-design, your focus. It's really important to develop goals, vision, principles. Asset mapping, like that chart I showed you. You have to document your current needs, your gaps, your concerns, balance that against your current services, support what's working well, and build on what you have. Collaboration. Build the model, leverage existing assets. Implementation. Consider access points, services, staffing, funding, intake, coordination, administration, pathways to housing supports. For us, this is, because we're coming at it from housing, we always have that in our mind, but it's a bit unique from other healthcare models that might not have as strong links to housing supports. So that's really important for us. Validation, regularly test out your work. Participation and inclusion. The roles of diverse people with lived experience is key. Local hospitals for us is key. Integrated health teams are essential. In terms of outcomes that we've already achieved, so as I mentioned, the pandemic was the catalyst for some significant integration between health and human services, particularly with housing supports. And this work has allowed us to keep our momentum going and remain embedded in the community and leveraging existing assets and prioritizing future directions that are based on the needs we've identified as well as the voices of lived experience. So I just want to point out the homelessness being a shared priority in our health and housing systems. I can't emphasize that enough. There was so much work that went into to get that acknowledged. We know there's a lot of vulnerable populations in our society, but being able to speak to the health system folks and say, this model is replicable for other vulnerable populations that your priorities have identified, but it's very important that we all be on the same page when it comes to this. So my final thoughts about principles to guide your journey. Be brave, curious, persistent. I'll emphasize persistent. If it was easy, it would have already been done by now, and nobody's going to care about this as much as you, so keep at it. Try different things, trial and error. You never know. It probably won't be your first thought that actually gets you across the finish line, and you can get better through disagreement as long as you come out the other side respectfully. But keep your scope manageable. Don't try and boil the ocean on your first go. I'm certainly guilty of that. Find your focus. So what is most important to your work? What do you really want to focus on? You have to prioritize. You can't please everyone. You're going to get a lot of ideas about doing this and doing that and doing this and doing that. You won't be able to do it all, so you really have to get that focus on what you really want to do. Collaborate, communicate. Community momentum will bolster and validate your efforts. It does take a village, and it makes it really hard for people to say no when you have a lot of people behind you. And at the end of the day, have hope. Know you're doing something. It does change the lives of some of our most vulnerable residents, and I've seen it. I've seen it. Okay, I promised myself I wouldn't do this. Municipalities can lead program design and delivery. They, even if that means stepping outside of our comfort zone, which for us in housing meant putting resources into better understanding and partnering with healthcare providers and colleagues, because health integration has significant impacts on housing. And vice versa. It creates more innovative, comprehensive solutions to complex issues and can be grounded in existing community responses from both our health and housing homelessness systems. It is so hard not to be siloed, but it's so important not to be siloed. Municipalities are not set up to solely fund health care. That's the province's job, and in Ontario, that would be the Ministry of Health and Ontario Health. And sometimes it can be accessed through local partners of our health system. So over the long term, we will be amping up our efforts to advocate to the province of Ontario and others for appropriate, sustainable health care funding for people experiencing homelessness in Peel, especially if you don't have medical professionals ready to lead the charge. Usually you need physicians, at least in Ontario, to lead funding applications. It can be a huge barrier. And for us in Peel, there's added urgency because we have a limited shelf life, and we really want to get these services off the ground. So thank you very much for your time.
So thank you for that great presentation, very compelling. And one of the things that we know, and I think probably the reason anyone is here in this room, is that you see homelessness and housing through a healthcare lens, or at least you're trying to. And I think that's a very good lens through which we can look at it. We can look at it through a number of lenses. Human rights is another one. But I think healthcare is one of the most important. And I can stand here today and say that in our organization, the one that I'm privileged to lead, if we didn't have partnerships with the healthcare authorities in the province of Quebec, we wouldn't be able to do the work that we do. So this is your chance now to ask questions, but remember the rules. You need to have the talking stick. which is the microphone, because we need to hear your questions. So if your hand goes up, Kathleen's going to run and give you the microphone. You can ask your question. Just identify who you are and where you're from. And if you've got a specific question for one of the individuals, great. If you just are asking the question, then we'll get somebody up at the table to answer it. And please make sure you use the microphone when you answer.
Hello, is it on? Yeah? Hi, my name is Jessica. I am from Montreal. Thank you all. Those were exceptional presentations and very inspiring. And I'm just grateful that I was able to hear it all from you, so thank you very much. My question is for Erin. I'm curious about, so you are from municipality, and so you are housing, and so then you created programming. You're not a community-based organization. You solicited healthcare services. Where's the funding currently coming from for those nurses that you have on site? Is it something that you're funding municipally, or have you got that funding coming from the provincial government already?
We're funding it from municipal coffers.
So are you paying those, like, are they private nurses that belong to you? Or are you paying, like, back into the provincial system? Like, how is it functioning?
We have contracted out services.
Okay.
Yes.
So they're private nurses for you,
Correct.
basically?
Yes.
Okay. Thank you.
Other questions? Just stick your hand up. Got one up front here, and we've got one over there. So whichever one you want to go to first.
Hi there. My question is for Jose. We actually met at breakfast the other morning, so hello again. I'm a police officer in London, Ontario, and so I saw the video, and I saw there was an inspector in your video, which I thought was cool. One of the things I'm constantly trying to do, and it's difficult, is find creative solutions to the justice system. And I'm not suggesting all your clients are participating in the justice system. However, it is a concern. I'm just wondering if there is a partnership there, are there creative solutions in your area that are working? I'd love to hear that.
So we reached out to the Ontario Provincial Police and stated very clearly that we wanted a partnership. So there's three that I can speak to. One being our Sioux Lookout supportive housing. When we opened, we really wanted to do two things, and that was to form a better relationship with justice and policing in the community. And we wanted to have their input on our policies, our procedures from their lens. Our goal was to improve the relationship. And the inspector that was on the video assigned a sergeant to us. So he worked with us, I would say he started working with us about a year out on reviewing everything from their lens. The other thing that they did was all of their officers had to do a friendly visit to the unit every day. There had to be one on record. So it didn't come without some pretty tough conversations, some pretty tough learning, but I think it definitely improved. To have somebody come by for a cup of coffee rather than picking you up and putting you in a cruiser is a big deal. So that was the first, and in the shelter and safe sobering, we're also working very closely, not only with police, but with the emergency department on that assessment. Are they safe for safe sobering? How do we make sure we keep talking to each other? And that's going very well so far. Thankfully, we've been working with them since 2018, so if we pick up the phone and we have those tough conversations, we come away, we agree to disagree sometimes, but we never stop working on improved outcomes. And our third is that we are a coordinated access reaching home designated region. The Ontario Provincial Police sit at each of our 9 community-specific case conferencing tables. So it's usually a sergeant, or sometimes it's a community officer that sits at those tables with us. So that was huge, right? Because they can give us a lot of advice on things that we can improve from some of our situations.
Very good question, and I think one of the things that we all know, and probably everybody in this room knows, is that partnerships with law enforcement are good leverage when they work. So that really matters. Julie, you had a question.
Oui. Sam, est-ce que tu vas pouvoir m'aider pour la traduction?
Oui.
Merci. Donc, merci vraiment pour votre présentation. Moi, ça me donne beaucoup d'espoir. On est en train de développer la santé, justement, après pandémie. C'est pas qu'on n'en a pas, mais on va vers la même vision que vous. Donc, c'est inspirant, ça donne espoir de continuer. Et je sais que vous travaillez probablement très fort parce que c'est beaucoup d'instances à mobiliser. C'est pas facile de tous les mobiliser et d'être justement coordonnés et être en partenariat avec les autres organismes pour pouvoir justement faire bénéficier à de plus en plus de participants, de nos participants, dans le fond, à des services de santé équitables. Et chez
So
nous,
just before you continue, she's saying that for the benefit of the room, if you're not understanding, her agency, her organization is in the process of forming partnerships like the ones that were being talked about. And she comments that, first of all, she appreciates the presentation and that there's a lot of things that are not easy to do. So, la question.
Oui. Donc, la question, nous, on a des gens qui arrivent chez nous avec des soins aigus, donc oncologie, soins palliatifs, et nous savons déjà que quand ces gens-là ont des diagnostics, s'ils retournent dans la rue, ils n'ont pas les traitements. Avec ce qu'on veut faire dans notre continuum et dans la coordination avec d'autres organismes, c'est qu'on veut maintenant aller, sachant que 90% des hôpitaux nous réfèrent les personnes, c'est 90% des personnes qui sont référées par les hôpitaux, faire l'inverse. Aller, nous, dans les hôpitaux et faire de la prévention, parce que nous, on les voit, c'est nous qui faisons le repérage. Est-ce que vous avez pensé à la prévention maintenant dans votre programme?
Okay, so the question is around the notion of there's so many people who come into their particular organization who have issues with oncology or a variety of even palliative care, because I know your agency, Maison Supérieure in Montreal, has a palliative care unit in the agency. If any of you want to know about palliative care, go talk to Julie, because it's a place where people experiencing homelessness can spend their final days in dignity. The question that she's asking is, have you thought about sort of inversing the thing? Because we're going to always get recommendations from the hospital system who are going to be looking to save money, to your point, that $250 to $1,000, I'll call it, just round numbers. Have you ever thought about going in the other direction and going into the hospital system and doing preventative care before they arrive at your place and partnering that way?
We have some great partners in our hospitals, and we are starting to explore with them the possibilities. I'll just say, our hospitals are really overwhelmed with so many issues for many, many reasons, as we all know. And coming to the agreement that homelessness is a shared priority, which I repeated, is important because it opens more doors. And you really need the hospitals on side. And so that is something that we're looking at, is do we have opportunities to have more direct engagement with our hospitals? The Mississauga Ontario Health Team has also it's just been announced they're going to be accelerated in the powers that they have. So we're hopeful that will also bear some fruit and we can do some more prevention services. I would also say our community nursing program, where we have a nurse practitioner and a couple of nurses that go around to our various sites and provide primary care, is also a way to be more preventative in terms of diverting folks from our hospitals, at least from EDs. And we have people that are invested in health promotion and education, particularly around diabetes, sexually transmitted diseases, things like that. But there's always room for more. It's just our resources are so small that we would love to be able to be more proactive, and we will get there. But just by having these services in place has created, I think, a bit more capacity in the system that we need to explore further.
Anything else to add?
Sure. I can add that our on-site RAM clinic, so rapid access to, they also do primary care, that has really opened a lot of conversations, right? So, and that was available in 2 of our shelters. Our smaller shelter had a nurse practitioner coming for a clinic once a week. However, that ended because the hospital is closing their ED because of staffing. The other thing we have, because we are a District Social Services Administration Board, is we administer emergency medical services. We have a community paramedicine program that is focused on seniors currently, but we do have seniors in our shelters. And along with the community paramedic, we also have a community paramedic case manager, so a social services worker that accompanies them. So we're doing a lot, we're trying to really wrap services around individuals in our region. That is having some really good traction.
Thank you. Question here.
Thank you. I'm France from Moncton, New Brunswick, and there's French people outside Quebec. I'm kidding, Sam.
You're absolutely right. And
okay.
it didn't occur to me this morning. That was a definite miss on my part. Franco-Ontarians, New Brunswick, Nova Scotia. I did CBC Radio Canada yesterday morning across Atlantic in French.
I'm kidding. So this message, I guess, is for Erin. So one, thank you for the breath of fresh air to see municipal, like local government taking charge. I know the funding's different for most of the other provinces, but I don't think at the end it matters because we all need to take charge. I'm a nurse practitioner in New Brunswick. I think I forgot to say that. So when you're frontline and everybody's like, it's their fault, you know. So I guess thank you for doing that. And we also have an outreach clinic, I guess, that we started in New Brunswick, in Moncton during the pandemic. And I guess it's more of a tip, I guess, because you're right, resources are scarce, so you can put all the positions you want. There's less bodies to kind of fill those positions in healthcare, but we teamed up with public health, even coming with us to the shelters to give immunization and all that, you know, even screening, all that jazz, I should say. So then it doesn't just fall on the nurse practitioner, the nurse that's surrounding. So that did help quite a bit in mental health and addiction as well. So, but thank you I will be interested in seeing your model.
Thank you, and I'm serious. I'm happy to. When we started this journey, it was intimidating because there's a lot of really mature homeless healthcare models already in place, and we weren't starting from that place at all. And so I'm happy to start up a little group of folks and we can share ideas. It's really heartwarming to hear your interest and know that we are making a difference.
And I can plug the app at this point too, because in our app you can look up anybody, including our esteemed panelists here, and send them a message, communicate with them, start up your small group of chatting with each other, continue the learning process. This conference is the meeting point. So there's my promo for the app. Go ahead.
I also have a question for Erin. Thank you for both your presentations. I'm coming from the Winnipeg Health region, so I really appreciate your comment about it being a shared priority. I'm curious about the starting point coming from housing and if that influenced how people transition away from the resource that you've built. When it starts from a healthcare perspective, sometimes that focus or that transition point is when somebody achieves wellness. And I'm wondering, because it started from a housing perspective, if transition happens when people achieve housing.
People want housing first, generally. They're not as interested in healthcare, perhaps. So part of our co-design process and even speaking with health leaders in our system was to clearly define the expectations of this project and what it is and what it isn't. We are also doing work in supportive housing. We're doing work in building new supply, but that's running on a different timeline than this work. We know there's immediate needs that we are meeting and need to expand to meet, and we know that safe, affordable, appropriate, supportive housing is a key component to success, but it can't run on the same timeline. And the notion of transition and how we incorporate transition planning into the model is there, but that will be a work in progress, and it's really going to depend, in our specific case, on who ends up leading this from a health perspective and what happens to housing and homelessness services in the region of Peel as of January 1st, 2025. So for those in the room that might not know, We are slated to be dissolved into the 3 lower municipalities, so the structure of regional government will no longer exist. And right now, a transition board will be making confidential recommendations to the province about how those services will continue to be delivered. So there is some uncertainty around what's going to happen. We know the need is there, and the services will be delivered, but we're not sure by which vehicle at this point.
Got a question in front here.
Hi, thank you for your presentations. My name's Elzara, and I'm a researcher. I study healthcare coordination between the emergency youth shelter system and health system in Toronto. And I have 2 questions for Erin. My first question is around what coordination of care processes look like when people experience crises that perhaps cannot be addressed on site at shelter. So are there any defined processes, and what might that look like? And then my second question is around policies, specifically if the region of Peel has considered any policy change related to information sharing between and across these sectors, between health and housing, because from what I've heard and seen, information sharing policies and privacy policies act as barriers in communicating important information related to young people or just people in general, health information. So if you can just comment on those two points. Thanks.
So Housing Services at the Region of Peel is in the process of becoming a health information custodian and a HIMPI, Health Information Network Provider, so that we are not as stuck with information sharing. That process has taken a couple of years, and we're hoping to achieve that final status soon. But it's been a significant barrier for us when we're trying to help our clients, and we haven't been able to talk health with health providers, so that will help make the transition seamless. So we're hopeful that when we get the green light, that will be a game changer for us, 100%. In terms of coordination of care, this is again where it gets a little sticky for us as being housing, not health. We do work with our contracted service providers on these issues, and we have housing support workers at the region that provide case management services. We have CMHA that we contract out to that provides supports as well. So it's an ongoing struggle to coordinate to the best of our ability. We are a bit overwhelmed with the overwhelming need in our homelessness system right now. We're completely beyond capacity. We have other projects going on where we articulate the need in our system and the gap that we would need to address. It's in the billions, but it's important again to lay the foundation of where we are and what we would need to fill the gap and try our best. But it's definitely an ongoing work for our staff. I hope that answers your questions.
Other questions? This is your, sure, go ahead, and we got one in the back too. Jessica, you're going to get your chance next.
My name is Kathy, and I'm from Nanaimo, BC, on Vancouver Island. And I don't actually have a question, but rather a comment. If you come into the entrance area of downtown Nanaimo, you'll see that it's nothing more than fences and gates. Unfortunately, the way our system is working, people are being pushed away from our major entry points, or however you wish to call it. But there's a building in Nanaimo that's very, very famous, and it's been around for, oh my God, for as long as I can remember, more than 60 years, 70 years for sure. And the building has gone through much transition, and a few years ago, a pilot project was created by our community to help those artistic people who were unhoused find a place for art and find a place for belonging. And it became an absolutely beautiful muraled building. But what was exceptional about it, and the reason I bring it to your attention, is that these people who created this beautiful building also created a sign on that building, and the sign says, "Housing is health."
well, maybe we'll take the question in the front here too first.
Hi, my name is Vesna. Thank you so much for your great presentations. I'm coming from Toronto, Fred Victor Center. It's a large community multi-service agencies, health and housing and employment and all sorts of things. So I've been coming to this conference for years now. And what I'm noticing this year, the flair is a bit different. It's like very emotional from one workshop to another, that, you know, people are talking about being overwhelmed, that the need is really great, that there is a sense of urgency and crisis, that there's more people that are homeless. There's just this theme that strikes me at this year. And I was just wondering if, you know, you are aware, with all the great work that you're doing, are you aware of any advocacy efforts through your networks in terms of leadership, advocating to levels of government, any sort of projects or such efforts that have had success that you can highlight?
So I think I'm going to start with our supportive housing units. We opened our first one in 2018, and our district had none. We had a high complex mental health through CMHCA, but that's it. Since then, we've advocated to open an 8-unit in Red Lake, and a 30-unit is about to open in Kenora. And that was through a partnership with, again, Ontario Aboriginal Housing. A lot of our First Nations communities are really on board for these types of housing models, because we don't want people in shelters. And I listened to Aaron's comments on being overwhelmed and overflow. 2 of our shelters are in that situation. So the Sioux Lookout shelter is 22 beds, and they run at 28 to 30. And that's not including the treatment stuff. So overwhelmed is putting it mildly. So our municipalities lobby, the District Social Services Board, our CAO, Mr. Henry Wall, is very active. Our First Nations communities, we're all on board for these services. So we are continuously advocating for improved services, not only in homelessness, but in other sectors as well, to improve outcomes for anyone in our region.
The region has actually very recently just come out with a new advocacy framework that we are promoting, and maybe if my director watches this streaming episode down the road, she'll be glad that I've been able to talk about it. So I'm happy to talk about it offline with folks who are interested, but its acronym is HOME, and it's about housing for homes, housing for everyone. Happy to go over it with you, but advocacy is a key element for us to educate residents in Peel, educate our local and regional councillors, keep reminding our senior levels of government partners about the need in our community, and advocate for what we think is appropriate. And not just advocacy, but solutions. So we always, as part of our advocacy, always come to the table with, this is what we're already doing. We're not sitting back and pointing the finger. This is what we're doing and why it's important and why we need your help to get across the finish line.
Yeah, I think we cannot ignore advocacy, can we? And it's like I shared with you this morning, it's also about changing the public's perception, because we're certainly seeing more and more, the popular expression is NIMBY, right? Not in my backyard. And what's happened over the years in Canada is that homelessness visibly has migrated out of merely the rundown areas of a city center and is now appearing in suburbs, in small towns, in regions. And so it's provoking a response. And if that response is not well understood or not well educated, and it's our job to do that, then we're going to have to make sure that we do our advocacy the right way, where it's not just government, it's also making sure that we try to alter public opinion. So, any other questions? Yeah, Jessica, you had one.
Thank
Yeah, sorry, it's me again. I realized I had like a follow-up question to my question as the mic was cruising around, and it might be redundant now. I'm curious from both of you, in Sioux Lookout, are your health services provincially funded, or are you funding them yourself? How did you lobby to get the provincial government to have those services permanently allocated to you in a community setting? And then, Aaron, you're advocating for that in your services, if I understand, and I'm just curious what the major pushback reasoning is from the provincial government into why they can't just throw a couple nurses your way. I hope that's clear. Thank you.
So we are very lucky, and our nurses come to us in partnership. So the Maniawan staff is funded through Maniawan, and Northwest Health Unit Public Health nurse is part of the programming, and it's their partnership contribution. We did receive funding for the treatment facility that is in development now, so that's a separate budget, but those two programs are coming to us at someone else's cost, so it's a huge bonus for us.
Okay, so coming at funding opportunities from a housing lens is different from how, in Ontario, how funding works from a health perspective. A major barrier for us is not having a physician or physicians in Peel that are able to take the lead on a sustainable funding application to the province seeking funding. We do have healthcare agencies in Peel that have applied for funding, and there may be opportunities if they're successful, but right out of the gate, we don't have that resource. We have tried knocking on the door a few times, but they're not interested in creating new payment agreements with new entities, certainly not municipal governments. So, and I understand that. Our health system is undergoing significant transformation, has been for many years, and the hope is to transfer the responsibility sort of from the top into local Ontario health teams that will fund projects. And Mississauga has been accelerated for that, so we're hopeful that there will be opportunities to find new money. My understanding is existing money will be flowing there. The challenge is always finding money for new programming. Tried to make the case that we're a rounding error in someone's budget for the amount of money that we would need to make a sustainable model, which I'm trying to follow my own advice and not boil the ocean and just keep it really basic to start off with, knowing that probably it will evolve over time and be sort of like a patchwork quilt of adding on this position and this funding source and that funding source, but that's kind of the way it rolls, and in a way, it helps keep you more flexible, and then you're adapting to the changing needs in your community anyway. None of us could have foreseen, I think, what is happening in our emergency shelter system in Ontario in the past year, as an example. So we are trying to better understand the health system and the funding, and we've made some great contacts, and that communication and collaboration with health coming from housing is so important, and to keep that going. And we are in a really great place now that we might not have been able to imagine before. So I'm hopeful. It just takes time, and it's hard to be patient when you see the immediate needs and you know what needs to be done, but you can't get there in a fast enough time. I'll leave it at that. Thank you.
So what you're saying is, let's not waste a really good crisis.
That's
Yeah.
right.
Yeah.
That's right.
So if we agree that we're facing a crisis, let's take advantage of it. Another question here at the back.
Yeah, hi, I'm Dave Campbell. I'm a physician and health services researcher in Calgary, and I used to work in Toronto. I'm struck a little bit, congratulations on the fantastic work you're doing, but I'm a little bit puzzled by the fact that you mentioned you don't have any physicians that you can partner with who are willing to kind of help you with these funding applications in Mississauga or in Peel. I know there's a whole network of physicians who are interested in this in Toronto, the Inner City Health Associates. There's 20 or 30 physicians. So I'm interested in, can you speak to, why that hasn't percolated over next door to Peel? Like what, what types of efforts have you tried? I know University of Toronto Mississauga has a kind of budding health campus, and there's some network activity happening there in terms of health. I know a lot of it's concentrated in the downtown Toronto area, but it's striking the difference, I guess, between Toronto and Mississauga to me.
And Aaron, this is being recorded.
How much time do you have? This was part of my learning curve to really understand. So Peel is somewhat fragmented in how it delivers primary care. Because we don't have more family health teams, community health centers, it can be difficult, I think, to mobilize resources, and it would be really daunting to, if we did find a physician who was willing to lead the charge, to do that without other supports, like what ICHA has. There are ICHA physicians who are interested in coming to Peel, but it's kind of a chicken and the egg thing, where we need someone to take the charge. Dr. Naheed Dasani has been helping guide the discussions, but he doesn't have the capacity to take on Peel, which I totally understand. So it's difficult, and happy to chat more offline about why the Peel landscape is what it is. It's also part of the suburban homelessness issue, where it can be more of a challenge when you're looking at a Toronto model where there's a lot of services concentrated in specific neighborhoods. Peel is more spread out and has more hidden homelessness.
And I think the other piece of the puzzle too is we have to recognize that all of us in this room are from all over Canada. And so our situations are going to look quite different, but it's interesting to see the perspective from Peel. I'm going to look for maybe one last question before we all go. Is there any burning issue that somebody wants to ask about? And if not, yeah, there is one. Yes.
Hi, my name is Rachel. I'm from the city of Edmonton. I think my question's for Aaron. I'm just wondering, you mentioned, I'm kind of feeding off of Jessica's questions. You mentioned that there is essentially like regional dollars that are paying for healthcare providers for nurses. Did you have the delegated authority to just make that decision, or did you have to go up and advocate to your governors and your elected officials? And what was like the turning point in getting them on board and doing that?
We've been really fortunate that our council has always been very, very supportive of housing and homelessness issues in our community. We did have to go to our council and ask permission. So that would have been a few months before we opened our Dundas Street shelter, to ask them if they would give us $6.5 million to run these programs for 19 months. And they very amazingly absolutely supported it. And our council, I think, is our leaders in this field, putting their money where their mouth is, not just for homeless health care, but on a variety of other issues, where sometimes out of frustration, we get tired of asking, so we just put in our own money and plow ahead. So we've been able to be innovative and get the experience that we needed with this interim model of care, which will help ensure that our sustainable, fully integrated model of care will be that much better based on what we've learned on our journey to date. But without the support of our regional council dollars and our regional council, it would have been impossible. So we're very thankful about that.
I think that's part of the message. Build allies. We all need allies, because as passionate as all of you are, we're not going to get there alone, are we? So I want to express my thanks to our panel here, and why don't we give them a round of applause.